All right, welcome everyone. Just want to say we have great audience. We have over 700 participants for this webinar. So really appreciate your time. We're going to be talking about the reality of Medicare denials after settlement. I'm John Kane. I'm the Vice President of Strategy for Ametros, and I have two colleagues with me, Jayson Gallant, and he is the Senior Strategic Account Executive at Ametros, as well as Shawn, Deane, and he is our General Counsel and Senior VP. So let's go to the next slide here. All right, little disclaimer here. This webinar is for educational purposes only. This is not to be construed as legal tax advice or any policy guidance. If you have legal questions, please seek counsel from your attorney. All right, next. All right, some housekeeping tips. So everyone is muted automatically. If you're unable to connect audio through your computer, you can also call in by phone by toggling to the phone call option. Nice little diagram over on the left. You can ask questions or seek technical help at any time by typing a message to the staff through the chat feature below. If you need any further technical assistance, please email marketing@ametros.com. And at the end of today's event, we do encourage you, there's going to be a quick survey. Please take a few minutes and provide us with your feedback. And the bathrooms are down the hallway. All right, let's open it up for a polling question here. All right. Have you heard of an actual Medicare denial involving an MSA? So this is post-settlement. So it's a yes, no. Just trying to get a sense from folks on if they've seen one of these or heard of one in the past. And we're going to give it a few minutes, or at least a minute, give people some time. And then it should tell us what the percentage is in terms of yes, no. All right. So in terms of the poll response, about 40% of you have heard about these denials post-settlement. So this is an approved MSA through CMS, and the medical provider bills CMS, Medicare. And what happens is there'll be a denial that's sent out to the Medicare beneficiary. So 60% of you said that you haven't heard of it yet, and that's actually a good thing. We're really going to get into the process, the data, and some of the details here. All right, next slide, please. So we're going to get into a little bit of the background here. In terms of the study, we collaborated with ResDAC, so they're one of CMS's contractors. They collect data. We're able to access this information. We took a statistical population, about 5% of MSAs that were submitted to CMS and approved. And we looked at the denials within that group. In terms of the timetable, it was between 2018 and 2020. So we had a good sampling of claims. And I'm going to have Jayson in a few minutes, talk about the results of the study. Next slide, please. All right. So how does CMS get these MSAs on their radar? And more importantly, what are they doing in terms of, benefit coordination? So we get a few different buckets here. The first is always. So with responsible reporting entities, and we're talking about Section 111 reporting, the REs have a responsibility to provide the information to CMS to determine whether or not the person's a Medicare beneficiary. And if they are a Medicare beneficiary, it meets a certain dollar threshold, then there's an obligation in terms of ORM reporting, which is ongoing responsibility of medical if the case was accepted. So that information, importantly, the codes, ICD codes, are put into benefits coordination. From there, we're going to talk about, the common working file. The next grouping is pre-settlement. So the primary payer. They have, with the MSAs, there's a choice whether or not to voluntarily submit to CMS. If they voluntarily, submit the MSA, then the workers' comp review contractor will review the MSA, for appropriateness, and then provide a determination letter back to the insurance company or self-insured. So in that situation, they're looking at the injury codes, and again, they're documenting that information. Again, this is, benefits coordination. We want to make sure that the appropriate party is making, payment on the medical services. And then at the time of settlement, the primary payer informs BCRC of the settlement. It's known as TPOC, which is total payment obligation to the claimant, as well as ORM termination. So if the MSA was submitted and finalized through the submission process, the settlement documentation also needs to be forwarded for conclusion of that CMS determination. From there, the BCRC, at the time of settlement, what they do, and this is important, they place a marker in the common working file. So this common working file is used by the Medicare administrative contractors. So if a bill comes in post-settlement and there's an MSA involved, they're going to see who's primary. Is it the workers' compensation carrier? If it's already settled, the answer is no. Those funds should be available by the injured worker to make payment for the medical expenses related to that work-related injury that would otherwise be covered by Medicare. So if a medical provider does bill Medicare, it will likely be denied. And then you have the post-settlement, so you have the individual that's self-administering, so they're responsible for accounting for all these MSA funds. They're also responsible for that annual attestation and making sure that the funds are used appropriately. And should they exhaust the funds, then they need to send an exhaustion letter to BCRC outlining that they spent the monies and that they're looking for Medicare to then take over. And then finally, you have the doctor's office, and we talked about this a little bit. So if the doctor submits the bill to Medicare, the Medicare administrative contractor will review it to determine if those injury codes might be related to this MSA. And if they are related, then they're going to deny the payment. So the study really focuses in, on these, approved MSAs through CMS. Next slide, please. Jason, if you can just advance it one slide. All right, so, we talked about the Medicare administrative contractor. they're the ones that would deny the payment. And if you go back just one slide, Jason, you'll see a Medicare summary notice. And what this does is it outlines the medical treatment and the fact that the MAC is denying the payment on it because the funds should have been paid out of the MSA account. So, at the bottom, I'm going to try and read this really small text that's highlighted. It says, your claim has been denied by Medicare because you have funds set aside from your settlement to pay for your future medical and prescription drugs that may be related to your injury. So this is the letter. It also provides information in regards to how that Medicare beneficiary, can appeal this process and look for a redetermination if for some reason they feel that this wasn't, related to the work injury. So we are seeing these letters going out at this point. And, we see these letters, in the future. I think we may see even more of these letters. So important to know that this is on Medicare's radar through Section 111 reporting, as well as they've taken, a stance in terms of benefit coordination. If, for some reason there's funds available in that MSA, they do expect that injured worker is going to pay for it first. All right, so I am going to turn it over to Jayson. And Jayson, just a quick question for you. So in terms of this research and study, what inspired you to do this work?
Yeah, so thank you, and I have to apologize to everyone. I'm having so many technical difficulties, but so actually this letter was something that I had found out about back in 2018 from an injured worker that I was working with a claimant's attorney who post-settlement came to us and said, hey, one of my former clients is getting denials from Medicare. And so, through all this, we found out through talking to Medicare on his behalf and kind of seeing what had happened, which was basically this individual re-aggravated his injury, and that's why he was not using the MSA funds because he was honestly afraid. And so fast forward to about December of 2019, right before the world shut down, Marcus Torbert, who a lot of you on the phone probably know, our CEO, our former CEO, and I were talking, and we kind of just said, we were like, we go to so many different file reviews and we talk to so many different injured workers and we see all these settlements happening, and, the overall industry doesn't really know that Medicare is actually denying. And I said, I was like, I'm going to put in a Freedom of Information Act request to see if Medicare will send me how many claims they deny annually. And so that process started on a much larger process of going through and getting connected with multiple organizations, and eventually to this organization, ResDAC, which is one of the CMS data contractors. And for those of you in our industry, that's a small part of the world. The people who look at Medicare data all day didn't really even know about WCMSAs. So, it was kind of enlightening for them to understand why I was doing this study. And it was obviously, for us at Ametros, where we do professional administration, the data is kind of validating for what we do in the sense that it shows that there is a need for professional administration. There is a need for this kind of being compliant with Medicare and doing everything that the CMS reference guide and administration toolkit says. And so, we were able to uncover some of this data. And, as for those of you on the phone wondering, this is a study that is kind of something that's put back to the ResDAC and CMS themselves and of public record, because that's kind of how you can do one of these studies. You can't just go and request all this data. You need to actually formulate a study and confirm what the results are. So this is ongoing. We're going to continue to post data about, things other than these types of, other than Part B claims when we can. And the kind of the feedback since we posted the study in the white paper has been really interesting. Some of the questions that came up, one of them, which was interesting, is, well, why are these denials happening, right? And so you see here on a 3-year average between 2018 and 2020, around 34,000 claims per year were denied, and that's spread across roughly 12,000 Medicare beneficiaries. And so the first thought is, well, everyone's misusing this money, right? And then, like John mentioned earlier, well, the doctor could have billed wrong, or, whatever it might be. And so one of the things was that we wanted to confirm that there was a workflow in place for when someone sends in their annual attestation letter of what their what the expenditures were out of their WCMSA, Ametros sending these in. And the folks at the BCRC confirmed that when the MACs are looking at claims and whether or not, they should take over, they do check the common working file to see if someone has properly exhausted and submitted that. So it is kind of refreshing that, when we send these letters in of the attestation on our members' behalf, that they are being looked at, right? And that they're being checked before sending up this denial. So I think the main thing to take away from the data is that there is a formal process in place on the side of Medicare, and they're not just denying claims because someone has an MSA, and they're saying, well, these ICD-9 and 10 codes match up with what the MSA says. We're just going to deny it and see if they properly exhausted or not, or, whatever it might be. And so that's kind of the piece that we really wanted to confirm on our end, just from feedback from the industry. And I think, one of the things that is interesting is when you look at these total unpaid dollars, the reporting is actually those dollars for the individual claims are what the Medicare fee schedule would be. So it's not even what the doctor is billing the patient at, right? So that's kind of what's reported back, is that Medicare is saying, because you as a Medicare beneficiary have, the ability to pay the Medicare fee schedule, and that's, generally how WCMSAs are priced out, that's what is, looked at as the denied claim amount. So just kind of interesting. Excited to talk about this data, as it was a really long process, and appreciate, those of you on the phone, kind of some of the feedback that you've provided since we've released the study. And also, it's been great getting to collaborate as a team and from Ametros, because you have, John, Shawn, and all of us, Porter, Marcus, our marketing team, and everyone who's constantly talking about CMS denials, and also what we do for our members, which is really help them make sure that they don't get denied and they do get this continuation of care. And then, looking at the breakdown by state, where these denials are happening, California, just from a population perspective, I don't think is really surprising that it's up there. Some of the states that I was really surprised at are Ohio, Indiana, and even Alabama and Maryland, just because of one, population size, and two, just where we see our overall member population and everything. So I think that the one thing to notice by the jurisdiction states is, are the states that are up here, I think what we're trying to do at Ametros is put this education out there, so the states that are getting more denials, or, for anyone that's settling a claim with an injured worker with a WCMSA, to understand, that that it is important to be compliant. You might not think that your client or the injured worker is going to continue to treat after they settle, but if they do treat down the road, that does mean that that Medicare looks at the WCMSA 3 years from now and says, you're continuing treatment for your knee injury. That's what was settled for back in 2020. So that is the primary payer. And just to kind of note too, I know that John mentioned this briefly, but these are just Part B outpatient claims. So, when we're talking about the general, I think a lot of folks have asked about, well, what's Part D look like and what do medications look like? Because that is all of those claims are so spread out amongst, different Medicare plans, in, the big Humanas and Aetnas of the world, that data isn't centralized like these claims are. So definitely something we would love to get our hands on and work with some of our partners at those different firms. But for now, this is what we're looking at. And I think it's telling that if it's 30,000 plus claims per year on the Part B side, it might be significantly higher on the medication side. And then, of course, really don't want to spend too much time talking about COVID-19, as we are all well aware. But we did want to kind of talk about the way in which we were looking at this data and interpreting it, which was that, there was a significant uptick in the later part of 2019 into 2020. And then when the pandemic hit, where you have all of the doctors that were seeing less patients for outpatient treatment and doing and seeing them less in the office, that's really why you see that dip. But we are going to be getting 2021 data soon, and we'll be talking about that as well. And I believe we have a question in the chat from Beth. So I'm just going to read it out. Please clarify in your study circumstances for denial and top reason denial. Is this because MD submitted bill that really should have been paid for from funds from the MSA? So this is a great question. And so one of the things that we don't actually know, the data doesn't show what the mistake was, quote unquote mistake. It wasn't necessarily a mistake, whether it was that the doctor billed incorrectly or if the injured worker tried to use their Medicare Part B benefit instead, or if the injured worker didn't properly report that their WCMSA funds had exhausted. So we don't know that part. We can make assumptions of what generally it was, but what we only know is that these denials were indeed happening. We did cross-reference a lot of the data we got to see if these bill denials ended up being paid for throughout the year. We didn't come across any that were. And so these are zero paid claims that were denied for the reason that the beneficiary has a WCMSA fund set aside. And then another question, do we know the position of Medicare supplemental carriers on denied claims? So that's a great question. I would actually defer to Shawn, Deane, but we do know from experiencing, like we have that denial letter, that we do see denials from Medicare supplemental carriers when a WCMSA should be the primary payer for that claim because of maybe an injured individual who becomes a member on our platform, mistakenly uses their supplemental plan. And so we do see those denied letters, but Shawn has a much more technical analysis of that question likely.
Sure, yeah, and John may be able to opine on it as well. I haven't seen directly any Medicare supplement plan issue a denial. When we were talking about items and services covered, you're talking about Part A and Part B and obviously Part D claims for prescription drugs. I certainly have seen Medicare Advantage entities which would encompass otherwise Part A and Part B claims for which a Medicare beneficiary has opted out of their traditional Medicare and paid an additional premium. And I've seen those Medicare Advantage organizations certainly issue denials and even attempt recovery, but that's in a totally different ballgame. But I haven't seen a Medicare supplement plan come in and act like either original Medicare or a Medicare Advantage plan. Usually those types of plans are meant to pick up different types of things like what Medicare won't cover, the difference like copays and deductibles or something of the like that, not items and services per se.
Yeah, and just to add to that, Shawn, when we're projecting out the MSA, those funds are 100%. There's no copays or deductibles with, the MSAs. So we shouldn't be seeing those supplemental plans.
Yeah, and I agree. Like, I think that on the Medicare Advantage plan, like you said, we do see that. But the other question too is, did you have any data on Medicare denials for WC claims that settled under 25,000, the 25,000 Medicare threshold, where CMS would not even review the proposed MSA? Is CMS issuing denials on these too? So again, we don't know the original CMS approved MSA amount for these denials. We just know that a WCMSA did exist. Now, when you look at one of the things that I think is kind of interesting and telling is when you look at the cost of these denied claims, the reason why I felt like it was important to include this, the average cost being $2,376 on total denied claims per beneficiary, that would total, likely more than 25,000. It's more than, for example, that I would have assumed it was, and that's really why I felt like it would, because that's a substantial amount of money to have to be paying back to be paying out on these denials. So it seems like it's might be less than the large scale of WCMSAs we see, but more on the individual claim side. And also that these denials weren't just happening one-off, right? It was individual beneficiaries who were continuing to treat, right? And were going to continue, that were getting denied multiple times, not just once generally. All right, I will read this other question too. How does the injured worker, administrator, and/or doctor handle a re-injury or aggravation to the same body part as the work injury? Example, PT for a sprain to a knee that was originally injured at work and the subject of a settlement of an MSA. So great question in the chat there, because that is exactly the scenario that we had found out about that denial letter back in 2018. And so again, I will let Shawn and John give their opinion, but what I will say is that it is what we've seen is that our team is calling on Medicare, right, and talking to the folks on these claims to find out on the injured worker's behalf. So generally, it's smart, right, to call into CMS and say, hey, this is completely unrelated. I have a letter of medical relatedness from my doctor. This is completely separate. Should I be using my WCMSA? That's probably the safest guarantee, but understanding that that's not always necessarily what's going to happen. But what we do know is that from this case, that it is our main case study here, and from experiencing situations post-settlement with our members, that they do look at the body part and the original injury that was included in the WCMSA. But I think overall it is pretty situational. Would you agree, John and Shawn?
Yeah, I mean, you might have a situation where you had a prior knee claim, workers' comp, settled out. And then the person had improvement with their conditions. They were released to, go back to men's basketball, and they went up for that rebound, came down wrong on it, aggravated the condition. And you think about it, when you go to a doctor, what's the first thing that they ask you? Is this accident related? Is this workers' comp? So they should be assisting in terms of, billing the right party. Now that might go through, and unfortunately, in some situations, that Medicare beneficiary that aggravated the condition that, it should have been picked up maybe by Medicare, has to go through the appeals process. But likely, they're going to prevail in that, it'll be determined that it was an aggravation and Medicare would then pick up. Jayson, you're on mute.
Sorry, just before I hand over things over to Shawn, I do want to say, one of the other pieces of doing this, not to embarrass my colleague John Kane, but prior to coming to Ametros, John ran the Medicare program over at Liberty, and seeing individuals like John and some of you on the phone today, and the importance of including professional administration and including these things in settlements on the defense side was something that was really powerful throughout this, because they were saying, you have individuals like John Kane, who a lot of you know in our industry, that are really paying attention to this stuff. And so this was to kind of doing this study that Shawn and I really did, was to confirm that, look, like, we have these people that are offering our services to be compliant and to administer the post-settlement WCMSA on all of their settlements. And is that really confirmed that it's necessary because are these denials happening? And so, it really, the data validated it, and we're excited to continue sharing things. And I think even from the questions that have been asked to Shawn, John, and other individuals at Ametros, will continue to help us make a better kind of emphasis for future studies.
All right, so we're gonna do our second polling question. And the question here is, what percentage of Medicare set-asides do you think are self-administered? And you can select from one of three: 90 to 95%, 60 to 65%, or 30 to 35%. And the question is, what percentage of MSAs do you think are self-administered? I don't have any great Jeopardy music. I can't really whistle. I'll defer to my colleagues for an interlude or entertainment.
I can Google that. So while we're waiting for a response there, just one tip out there to the responsible reporting entities. We can assist CMS, BCRC, and these Medicare administrative contractors with good Section 111 data.
All right, so 90-95%, or 46% of respondents here said they believe that 90 to 95% of MSAs are self-administered. 36% said they feel that 60 to 65 are, and 18% said 30 to 35% are. The group has it. That is the correct number. It's relatively high, and I'm always surprised at that number. I think it's a terrible disservice to a settling individual who has been in the throes of the workers' compensation system for years, to set them off with a pot of money that's between 50 and 150, if not more, $1,000, and expect that they're going to succeed and excel in an ecosystem, a treatment ecosystem that's set up to take insurance, and that they can be expected to present their MSA to providers and expect them to take the workers' compensation fee schedule and negotiate bills down and coordinate their care and go through the various record-keeping requirements that are associated with CMS's guidelines, send in attestation information within 30 days of the anniversary date of the settlement, and ensure that all expenditures from that account are used only for Medicare-covered expenses that are causally related to their injury. And frankly, it's just a human condition. Be expected not to have any temptation to use those funds to go to a casino or spend them on Christmas presents or their mortgage or their rent. It seems wrong, and it seems to me that number is pretty disproportionate, and frankly should be flipped. I'm surprised it's not 90% of cases that are professionally administered and only 10 that are self-administered. Cost, certainly, as Jayson can tell you, is not a barrier to utilize these services. It's less than the cost of and then preparing a Medicare set aside that's done.
Yeah.
So that's sort of my spiel on this particular question. You can go to the next slide. I do want to give a shout out to Jayson, because this study, the reason we're here today is because this is really the brainchild of Jayson and his tenacity in digging down the data and being inspired by seeing that going through that particular case, trying to help that individual who had issues with Medicare. So kudos to you, Jayson, for your tenacity there and sort of keeping up with digging down the data. And for a number of years, CMS have been telling us, yeah, we're denying cases, and we as Ametros we weren't seeing that because we were doing the work we were supposed to do with respect to administering the claim pursuant to CMS's guidelines and sending in that attestation. So it's a testament to the fact that we're doing the work we needed to do. So we're not seeing these, but I think there's a pretty strong presumption that can be made that while it's not overwhelming, it's not insignificant that these individuals who have associated denials from the data set that we looked at are probably self-administered MSAs. I think that's a relatively safe assumption to make, and I don't think it's terribly surprising. I do want to caveat this presentation too, because there was an interesting question that was asked, and we went through it quick, but it had to do with, are we seeing denials with respect to cases that are below the threshold? And I think that starts getting into the area of potential denials in regards to CMS's policy position they came out with in regards to the updated work comp MSA reference guide found in section 4.3. And this webinar is not about that at all. The timing just so happened to coincide with this study that we did, months and months before that we put this together. But I would recommend folks, I imagine most of the folks on this webinar are very interested in that topic. While we won't be covering it here, just to reiterate, this study had nothing to do with those types of denials. All of these Part A, Part B denial claims were associated with submitted MSAs, none of which we at Ametros were professionally administering, but MSAs that were sort of out there in the universe that were being handled, like I said, presumptively as self-administered cases. But if you have questions in regards to the issue of submit or non-submit, we're not here to talk about that, but I'd highly recommend folks to tune in to CMS's webinar, where I believe they will likely provide some updated guidance. So with that being said, what are some of the implications with respect to this particular study? as it relates to settling parties in the industry? Well, one, I think it's clear now, and it's irrefutable that denials are happening. I mean, because of the work Jayson did to run down this data and show that it's occurring. There are still some unanswered questions, and as Jayson indicated, we're going to be kind of in a way continually updating this study. I think it's an iterative process because we want to get to the bottom of what happened to these particular claims that we're looking at. Did the beneficiaries go through the appeals process, and were these overturned? Did these claims end up getting paid down the road? There are many aspects to the data that we're just not sure on, but that we're going to try to make a little bit clearer. But I guess what is clear is that these denials are happening, and they may be happening by mistake. They may be happening as a result of improper attestations being submitted. It could be that they're related to the timing of the attestations. Many MSAs are funded via annuities because there's particular savings benefits to doing that, to funding one. But annuities, it's possible because of a change in utilization, can exhaust and can temporarily deplete in any given year. And that's what makes the attestation process so critical to alerting Medicare of the fact that there are no more remaining funds. And as John outlined in very well in the process of how this actually works, the mechanics of it, it's why attestation is so vital, because Medicare needs to have a quick heads up as to the fact that funds have depleted, so Medicare can then step in and pay primary. I think it should also probably be a wake-up call to attorneys that are involved in settlements. I think for a long time there was sort of this feeling that administration maybe it's not the most important thing. We just need to protect Medicare's interest because we don't really have evidence that Medicare's denying claims. It's probably not happening. We don't really need to worry about it. I think that is a really bad philosophy to take because of what the data reflects. It reflects that it is happening and Medicare is paying attention to it. There are, if you look at the study that Jayson and I wrote, there are documents out there, documentation from Medicare that outlines the specific codes that get placed in a beneficiary's common working file when there is a submitted MSA. And there's, as John outlined, there's a very specific procedure that Medicare goes through in which they utilize the attestation information to code the common working file to properly coordinate benefits post-settlement. Given the strain on the Medicare trust, it's a very easy way for CMS to ensure that they're not paying when a Medicare set-aside is available to pay for those funds. And most likely, the first person that an injured individual is going to call up is their attorney, and their attorney is probably going to call the defense attorney, and the defense attorney is probably going to call up the payer carrier. So there may be some, if not direct, at least collateral or indirect exposure towards the parties. And then number one is the injured individual. As I indicated, with respect to the disproportionate amount of self-administration that occurs versus professional administration, these folks are out there on their own, forced to comply with CMS's stringent guidelines around document retention, ensuring how the funds are expended, making sure that accurate and timely attestation information is submitted. It's a lot to put on an individual who might not be terribly sophisticated in this area. Now knowing that it's not an insignificant number of denials that occur, I think it's incumbent upon parties who settle cases to ensure and to recognize at least that administration is just as key a component as protecting Medicare's interests. If you have a Medicare set aside that is perfect in every way and accounts down to the penny what an individual is going to need for their entire life, you fund it. The Medicare beneficiary goes off and on day one, they misspend the funds, all's for naught. All that work that you went through to ensure that Medicare's interests were considered and protected, and the beneficiary goes and spends it, and you didn't consider the post-settlement administration ramifications, then what was the point in going through all that work in the first place? I find it very unlikely that hold harmless indemnification language in a settlement order is going to satisfy Medicare in that regard. So that's my opinion on that. If you want to go to the next slide, and we'll kind of round things out by talking about some of the compliance aspects to it. So in my mind, the first thing that's incumbent upon an administrator and that we take most serious is ensuring that the funds are properly expended on Medicare covered items that are causally related to the underlying industrial injury. That's number one. It seems like it's a fairly easy thing, and for folks like us in the work comp industry, it is easy to conceptualize that, but for an injured individual receiving a medical bill or trying to negotiate a medical bill or understanding what's covered and not under Medicare, it can be a pretty trying thing, and there's a lot of room for error in that process, especially when they're dealing with a system of providers at the point of service that are only used to handling traditional insurance. I think secondarily is attestation, which is where the rubber meets the road in evidencing that the administrator, in fact, only utilized those funds that were expended on Medicare covered items and services. That in conjunction with the record keeping and ensuring that the funds are expended properly are sort of the three prongs to the compliance obligations that go along with a professional administrator. But I will say this too, I think a professional administrator that's worth their salt, like Ametros, who has an extensive network of PPO and PBM partners, including home health care and DME networks that they can utilize to achieve potential savings across all those spend categories, is really vital, especially where you're looking at instances of unanticipated utilization and possible temporary depletion, where you're looking to extend the life of that fund as long as possible in relationship to all the different allocation methodologies that are used out there to potentially contain costs. I think it's critical that cost savings are looked at. And certainly an individual layperson is not going to be sophisticated enough to go through the bill review process and try to get a particular bill down to work comp fee schedule or lower, or look for various savings avenues. They're not going to have purchasing power. They're not going to be aligned with the PBM or PPO network. So I think that can't be overlooked. And then just the fact that they can go to someone, they can call someone up like Jayson if they have questions and go, I need help. I don't know what to do here. I'm having a problem coordinating my care. These folks have been used to having an insurance adjuster, their attorney, a nurse case manager, a whole host of folks associated with their workers' compensation claim, and their attorney, and now they have a team of folks like Ametros that they can use. So that's sort of my, didn't mean to go off on promoting our services, but I think it sort of goes part and parcel with talking about the benefits of professional administration and also what comes along with it, notwithstanding the core compliance obligations that we're mainly focused on.
Yeah, no, that's a great point, Shawn. I think I really like what you said too, because one of the things that we've actually spoken to Medicare about is the way that we save at Ametros money for the members. And, I think that there's a thought of, well, individual so-and-so can administer their MSA without an issue, but it really is access to pricing. It's like our own insurance coverage that you use, you wouldn't be able to get network discounts wherever you go. Given that we are coming close on time, I definitely want to run through some of these questions because there are some really great ones in here. Dan Anders from Tower MSA just asked, has Ametros engaged in the Medicare appeals process on behalf of a client? How does this work? What is the turnaround time and success rate? What I can say is that we do have a team led by an individual named Robin Kavanaugh called Voice of the Customer, and another colleague of ours, Kathleen Correa, who do engage regularly with Medicare on appeals and issues about, if one of our members temporarily exhausted or if it's a bill that Medicare should be paying for. So that is something that we do handle on our members' behalf. We don't necessarily track it. And, because we do have a large enough member base, we are able to get in touch with Medicare fast and, they are used to hearing from us. Was there anything you would add to that, Shawn or John?
Yeah, no, just be clear. We don't handle direct the 5-level appeals process on behalf of our membership. We would refer them to capable, competent attorneys that we've partnered with to do that on our behalf. But in many instances, if there is, and fortunately, because we have our attestation process down to a science, we rarely see denials. And if there are indications of a denial, all my experience has been that there's been provider error, and we can usually correct that directly with the provider or a simple phone call to the BCRC outside of the appeals process. Always does the trick.
Right. And have you ever done presentation with applicants' attorneys? One thing that's really important for everyone in the audience to understand is Ametros' neutrality. So we speak with injured workers, applicants' attorneys, defense attorneys, everyone involved in the settlement to try to educate them more. And we do regularly engage. Anne did ask a good question that I want John, if you could answer. What is the most common Section 111 reporting mistake that carriers make? Realizing that, not necessarily very specific, but, what did you see in your role when you were with Liberty Mutual and kind of, especially your role within the MSPN network?
So fat fingers do happen. It's important that, when you're entering the information that, it's entered accurately and checked. I think early on, with Section 111 reporting, there could have been, over-reporting of injury codes. I mean, keeping in mind there's up to, I think, 19 fields for ICD codes. So again, the point that I made earlier, it's very important that, when you are, filing ORM or you're filing, your TPOC, that information is accurate. So it avoids these unnecessary, denials down the road.
Right. And then I'm just trying to bring up the chat box again. There was a question there about the difference between denials with self-administration versus professional administration, or the number of cases that we see as being self-administered, and how many attestations are submitted. We don't know those specific numbers, but what we can say is that we do have an increasingly high number of individuals who come to us once their case is actually settled to take over the administration because it is difficult for them. So just something kind of interesting to kind of note there. And from David Barlow, is there an expiration of approved MSAs? Also, once the MSA is approved, is there rationale for resubmitting the MSA, meaning once CMS has approved the MSA, is there a reason to send an MSA back to CMS for approval / update? If so, what would those reasons be? if the claimant expires before the MSA funds are depleted, what happens to those funds administered by Ametros? So Shawn, do you want to answer the first part of that question?
Sure, and John's closer to it, so to correct me if I'm wrong, but it's 72 months on the amended review process, right? So theoretically, the case hasn't settled. You'd have that long to take care of a new submission. If it was beyond that time frame, and you had previously submitted and gotten an approval, I don't think you could resubmit. I'm aware of no mechanism that allows for that.
Yeah, and there's certain criteria that have to be met. There has to be, significant change in medical treatment. I think it has to be greater than $10,000. So there is some criteria, built around that. That's with a CMS determination. If you go out and get, an MSA and you wait, 6 or 7 years, then obviously you should go back and get, reevaluation of that exposure.
Yeah. And I think too, just on the topic of denials for non-submits, I don't necessarily think that we preface this, but these denials are all on WCMSA submitted MSAs. So just something to keep in mind. We are not necessarily aware of any denials on non-submits, but we know that it's definitely a hot topic right now. For those of you know, I'll be at the MSA Masterclass in Washington, D.C. next week, and I'm sure that there will be a lot of talk about this stuff, and excited for Medicare's webinar this week as well. And then I'm trying to see if there are any more questions here. I think that's it. Oh, Shawn, did you want to answer is there a last question there?
So if the claimant expires before the MSA funds are depleted, what happens to those funds if they are administered by Ametros? So the question is, is to reiterate, if our member passes away and there are remaining funds, what happens to the funds that are being administered by us? Depends on what the short answer is, depends on what the settlement says. CMS indicates in question 10 of an approved WCMSA that the funds either go two places. They go pursuant to the settlement documents. They go to the estate of the deceased beneficiary, or they go to the payer if that's what the settlement documents indicated. So they would go one of two places pursuant to how the parties decided to settle their case. And our agreement with the individual member honors whatever the settlement and whatever the parties decided was going to be the procedure where the funds went to.
Yeah. Would Ametros take an injured worker on for administering MSA if it was put through as a non-submit? Yes, we do administer MSAs consistently that are not submitted to CMS. We administer non-MSA funds, liability cases that aren't technically in LMSA format. We really, one of the things that's really for us is the term professional administration, right? It doesn't necessarily come off the tongue super easily. I've been at Ametros for 6 years and my parents still have no idea what I do. So it's kind of, understanding for everyone on the phone is that, whether it's submitted or not, we will administer it fully, protect the injured workers' interests as best as we can, and still give them access to our savings and different things. But realizing it's right at the top of the hour here, I'll let John finish us off, but definitely want to thank everyone for their time. Excited for this webinar and more webinars in the future and speaking engagements to talk about this. And, for those of you, don't ever hesitate to reach out to the three of us and anyone else at Ametros.
Thanks, Jayson, and thank you to the audience. You guys had some great questions here, good dialogue. Don't forget that we do have a survey that we'd like you to take. Would love your feedback, and wish you guys a great day. Thank you.